My name is Tony Reiman, and the title of this talk is Multiple Myeloma Research. Hi, everyone. Bonjour tout le monde. It's a pleasure to meet with you today virtually and give you some information about our research. This KT seminar is intended to highlight the work of the Maritime Spore Support Unit and the NB-IRDT. And so certainly aspects of our myeloma research are well supported by the MSSU in particular. And we'll be highlighting some of those projects today, but I'm going to give you a bit of a broad overview of this particular line of research that we're undertaking, certainly with the support of many stakeholders in the province, for which we're very grateful. So I'll tell you just briefly about the research environment we work and the cancer research program more broadly we're undertaking in this environment. I'll tell you briefly about this condition, multiple myeloma, and focus a bit on some of our myeloma research and highlighting again the role of the MSSU. So this is an aerial view of the Tucker Park area in St. John, and of course in the foreground is the St. John Regional Hospital, and in the background is the UNB St. John campus. I've just circled a few of the spots where our team does its work. So in the foreground on the left-hand side, the Department of Oncology at the hospital is in Tower A here, and on the 5th floor we have our inpatient unit, and down on the 1st floor we have our outpatient clinic where we see patients. And on the right-hand side is where normally the Office of Research Services is located. They've been dispersed as some renovations are going on, but that's normally where the Maritime Spore Support Unit St. John node makes its home. And so we've got employees of the MSSU embedded in the Horizon Health Network Office of Research Services, which is very helpful in facilitating support of clinical research and research at Horizon. But of course, this group also supports research at UNB and with the Department of Health and other stakeholders across the Maritimes, really. In the background is the Dalhousie Medicine New Brunswick Research Building and Education Building. So the research lab space is located on the lower level on the right-hand side of this building. And so we have some space in there where we do some of this work. And so it's great to have all these resources in proximity to one another to enable this work, which really is a partnership with UNB, Dalhousie Medicine New Brunswick, Horizon Health Network, and others. So over the years, we've managed to build up the research environment. These are just some shots of the lab-based research team at Dalhousie Medicine New Brunswick. Of course, we've got a team over at the hospital as well, including the MSSU folks, some of whom are in the photo on the bottom, and then folks on the top are in the research lab. We have a clinical trials team as well, based at the hospital in research services that enrolls patients on therapeutic clinical trials at our center. So with this, we've been able to leverage these critical investments in health research in the province to attract external funds from other agencies and to build our program. So for the last 10 years or so, we've worked with the clinicians, the oncologists and hematologists at the hospital, nurses that specialize in doing research and clinical trials, data specialists, admin support. And then in the academic setting, we've got staff and trainees working with us on cancer research. We've listed some of the funding we've received from external agencies like the Terry Fox Research Institute, the Canadian Cancer Society, CIHR, of course, NBHRF and NBIF have supported us. And we also work with industry partners and others on clinical trials that we do. And over the last 10 years, we've attracted about $12 million in funding to the program, most of which is external funding. And we've tried to be productive. We've disseminated our work in international meetings and peer-reviewed journals. Amazingly, our work has been cited over 11,000 times in the last 5 years. So we're proud of our little program. The team at MSSU that supports our work, here's a list of some of the projects that our cancer research team has engaged with in collaboration with the MSSU and the IRDT so far. So first of all, we've been able to attract some additional funding from CIHR and partnership with NB-IRDT to do additional sort of innovative cancer clinical trials research, and the MSSU has supported us in this work and collaborates with the personnel funded with this grant. Together, they put on a workshop pre-COVID called Clinovation, looking at stimulating discussion about how we can advance clinical research at our center. You heard recently a presentation from Dr. Groom about how to streamline and make care more efficient for patients with lung cancer. Dr. Farinaz, our department head, is studying the clinical implementation of a stereotactic radiosurgery program for tumors that have spread to the brain. The team has helped us to write proposals and publish work related to clinical trials with the Canadian Cancer Trials Group, which is Canada's physician-led cancer clinical trials organization. We're currently working with a team across the country funded by CIHR and the Cancer Society on innovative approaches to cancer rehabilitation with an emphasis on virtual rehabilitation, which has turned out to be particularly useful during the pandemic when everything's gone virtual. Dr. Sharon Chu, one of our breast cancer surgeons, has been reporting the impact of outpatient mastectomy programs in partnership with the Delta Hotel in town. And we're partnering with the IRDT and Ted McDonald and others across the country on a very interesting project called Can Revalue, which examines the cost effectiveness of expensive cancer drugs in the real world setting, with the idea that often drugs are priced based on the cost effectiveness that's demonstrated in clinical trials, which is an ideal setting, but in the real world setting, the cost effectiveness may be different. And this could provide a framework for negotiating with pharma on more affordable cancer drug pricing. So these are some of the interesting projects that we're working on. Within this, we're particularly focused on a disease called multiple myeloma. This is a cancer of the bone marrow. So the cartoon on the left just depicts a person lying on their side in the clinic, put some freezing in and insert a needle into the bone marrow, which is where you make your blood. And we can withdraw samples of bone marrow. And this is where multiple myeloma tends to reside, in the bone marrow. And if you look at it under the microscope, this is a photograph of the bone marrow of one of my myeloma patients. And all these purple fried egg looking things are the bad guys. These are the cancer cells. This is a cancer of the bone marrow and of what are called plasma cells. So this is what it looks like. And this is how we make the diagnosis with the bone marrow examination in clinic. You can think about the symptoms and signs of this disease with the acronym CRAB, which is why I put that little friend up on the corner there. So this disease can cause calcium to leach from the bone into the blood, and this can make people sick. They have high blood calcium levels. These plasma cells produce antibody proteins in excessive amounts, and these can go to the kidneys and cause kidney damage. Sorry, I think I somehow muted my microphone by mistake there. So high calcium levels, renal or kidney damage, A for anemia or low blood counts related to the infiltration of the blood-producing bone marrow by this cancer, and B for bone problems. So these cancer cells eat away at the surrounding cortex or hard structural aspects of the bone, and this can lead to fractures and osteoporosis and bone pain and tumors in the bone that can compress the spinal cord or other critical structures. So this disease can cause a lot of morbidity. It's an incurable cancer for the most part, but prognosis has improved over the years as treatment has advanced with progress in research. So in the era before there was effective therapy for this disease, people typically lived less than 2 years. The average lifespan for people who were treated with older generation chemotherapies was about 2.5 years. Newer therapies were eventually introduced in the 1990s and 2000s that extended survival for patients to about 4 or 5 years. Some patients are eligible for more aggressive high-dose chemotherapy with autologous stem cell transplant. And we've got a program for stem cell transplant here at the hospital in St. John that treats patients from around the province. And this can extend survival by another couple of years If you integrate new therapies with transplant, these days, with the best available treatment, patients can live 7 to 8 years on average, and some patients live much longer than that. So encouraging progress, but still an incurable disease. Many of the advances in treating myeloma these days are with the approach of harnessing the immune system to fight cancer, things like CAR T cells, which some of you will have heard about as a new therapy that we can currently use as a standard of care treatment for lymphoma. There's also showing promise to treat myeloma, and other new immune therapies are in development. And hopefully these will further extend life expectancy for myeloma patients, or maybe even one day lead to a cure. So what are we doing in St. John? Well, we're part of a global and national network of researchers doing research on myeloma. And one of the things that is most gratifying is the opportunity to bring new therapies to our patients through participation in clinical trials. So these are systematic studies of trying to define what is the best treatment for a patient with multiple myeloma. And so there are several phases of clinical trial development, which we can get into another time maybe. But for patients who participate, it typically provides access to promising new therapies years before they're otherwise readily available. And we've been very fortunate to be able to provide some of our patients with these therapies in these studies and see great outcomes for them. And this keeps our center on the leading edge of advances in care for myeloma to participate in these studies. Gives us early experience with new therapies. And helps us contribute to practice-changing trials. And these are just a few examples of trials published in some of the world's best medical journals describing improvements in patient outcomes and new standards of care for treating myeloma with new therapies that we've had the opportunity to participate in and enroll patients on and be a part of. With the MSSU, or the Maritime Sport Support Unit specifically, this group has been instrumental in helping us to get another project off the ground, which is funded by the Terry Fox Research Institute, called the Multiple Myeloma Molecular Monitoring Study, or M4 study for short. So in this study, we're working with about a dozen cancer centers from Vancouver to Halifax. Many of the major centers across the country are participating, and patients are enrolled at those centers who are newly diagnosed and heading for the best available therapy with autologous transplant. Patients are providing blood and bone marrow specimens, which are being couriered to us, and we're banking these in our lab. We're separating out the malignant cells using molecular cell biology techniques to separate the cancer cells from the rest of the bone marrow, so they can be isolated and studied and shared with the best myeloma researchers across the country. We're collecting data on the outcomes of these patients through another parallel project, the Canadian Myeloma Research Database. So we've been able to continue to steadily recruit patients to this study. Accrual sort of slowed down during the pandemic, but we've persisted, and we've been able to try to ramp up again. You can see a list of some of the centers participating on the right-hand side of the graph across the country. And so far we've got 85. Actually, I think we've enrolled another patient or two since we made this slide the other day to the study, and we're leading the enrollment to the study in St. John, closely followed by Halifax, and then centers across the country are contributing. And so this is very great to see the Pan-Canadian collaboration on the study. And patients provide multiple blood and bone marrow samples over the course of time, so we can follow their disease over time and see how it changes and evolves and develops resistance to treatment. We can look at the clinical implementation of new tools that are available to detect small amounts of cancer that persist in spite of our best available treatment, so-called minimal residual disease assessment. And we're using things like PET scans, as well as molecular and cellular analysis of bone marrow specimens that can detect as few as 1 myeloma cell amongst 1 million bone marrow cells. Much more sensitive than the techniques we conventionally use in the clinic to detect residual disease. And we know that these techniques can predict outcomes. The deeper is the remission, the longer is the remission. And so we're looking at how to implement these in the Canadian environment with this research. We're partnering with colleagues in Toronto and Calgary who are leading sub-studies on this to look at, do we still need to do bone marrow biopsies on these patients? Putting a needle into somebody's bone marrow can be uncomfortable. And, you can detect some of the abnormalities that are found in the bone marrow by looking at circulating myeloma DNA in the blood. And so we're working with the Genome Center at the Princess Margaret Hospital to analyze blood samples from our patients and compare to what we get in the bone marrow. And we're learning that we can detect a lot of the important molecular information about these cases in the blood. Nizar Velas, a colleague in Calgary, is very interested in what happens when patients relapse or their disease progresses in spite of the treatment that they're on, and using next generation DNA sequencing approaches to dissect the mechanism of resistance to treatment. And so we're learning a lot about how our current and experimental even therapies become resistant to treatment and the molecular mechanisms behind that, so that we can then do further work to figure out how to circumvent or overcome that treatment resistance and improve outcomes. Another colleague is looking at so-called myeloma stem cell population. There's a group of drug-resistant, slowly proliferating cancer cells that are different than most of the cancer cells and do not necessarily respond as well to the treatment. We think this is an important source of relapse for these patients. So with Roger Tiedemann, one of our colleagues across the country, we're looking to isolate and characterize these myeloma stem cells that persist in the minimal residual disease state and try to figure out how to target them better. So that's a big study that we're proud to be leading from St. John. We're participating in some other important studies. This one called the VIP study is very timely. So we know that COVID vaccination is less effective in people with cancer, especially those receiving immunosuppressive therapy. Myeloma patients fall into this category, as do people with other blood cancers. And so we're participating in a study funded by the Public Health Agency of Canada, where we're examining the effectiveness of COVID vaccination in inducing immune responses in people with myeloma and other blood cancers. Samantha Fowler, who will be speaking to you today about another project she's been leading, is actively enrolling patients in our clinic into this important study of about 2,500 people across the country. So we're interested to see what we learn from this, how we can use it to improve vaccination strategies for immunosuppressed cancer patients. Sarah Bridges in the MSSU is our point person for entering patient outcomes data into the Canadian Myeloma Database that I referred to earlier. We can look again in the real world setting with these data on thousands of patients with myeloma across the country at how treatments work in the real world setting and what the outcomes are, and consider optimal approaches to using these treatments in the real world setting. And we've published a number of papers just in the last year from these data, which are proving very valuable and of interest to our colleagues internationally. I'm going to stop by just segueing into Samantha's part of the talk. So we work with a myeloma patient organization called Myeloma Canada, which was founded by a couple of myeloma patients in Montreal, and which includes people from New Brunswick and across the country. These are mostly myeloma patients and caregivers, and it's mostly an organization that helps inform, educate, and advocate for myeloma patients. And they do some fundraising and they do some research funding. And one day the late great Aldo de Alcal, who was one of the founders of this organization, called me to ask me, look, how should we be investing our research dollars that we raise? And I said, well, you're a patient organization. Why don't you ask the patients? And that's kind of how this myeloma priority setting partnership project was born. And I'm going to stop here and let Samantha tell you a bit about this project. I'll stop sharing my screen, Sam, so you can put your slides up.
Sounds good. And I'm very excited to have been part of this project and to be able to contribute to it. So I'll be happy to tell you more about that today. Just seeing if I can switch my slides on the fly. Can you see this?
Looks good.
All righty. So I want to spend the last few minutes of this talk today to talk about this project because it is our most recent success story, with it just being published a few weeks ago. And I feel it's a really great example of the type and the scope of work that we do, as it was driven by the MSSU team from our St. John and Moncton sites, with the support of Myeloma Canada and another organization known as the James Lind Alliance. So we followed this methodology developed by the JLA, which is a not-for-profit initiative from the United Kingdom that seeks to reduce the gap that exists between the research that is funded and conducted and the needs of the community. So that is the patients with the disease, their caregivers, and the clinicians who treat them. And the James Lind Alliance process emphasizes transparency and equity in all aspects of the process. And we felt that by engaging in this process, it would add rigor and credibility to our results. So we followed this process and we started by establishing a national steering group with equal membership of people living with myeloma, their caregivers and clinicians. And these folks were instrumental in guiding our priority setting process. Just trying to advance. Okay, great. The first stage in this process was a survey to elicit research questions about myeloma, and we looked at questions related to the diagnosis, treatment, management, and living well with myeloma. And this was a national survey conducted in both French and English. We got responses from almost 600 individuals across the country, and they had over 3,000 questions. So I think it's safe to say that the people who are affected by myeloma have lots of questions about the disease. And then it was my job to take these 3,000 questions and try to distill them down using the JLA guidelines to 76 summary questions. But we want to focus the future of research on questions that haven't already been answered. So we wanted to know if they were within the scope of our project. Some of them weren't. They were better suited for quality improvement initiatives, patient, public, or healthcare provider education. So these questions that we didn't include, they won't be lost. We are going to continue working with Myeloma Canada to address these questions that people had, but this left us with 66 questions that we brought forward to the next stage of the process, which, as I mentioned, was to see if they had been answered, because we wanted direct research, the funders to research that hasn't already been done. So we engaged with our evidence synthesis coordinator, which is another service that the MSSU provides to search for all systematic reviews, meta-analyses, and clinical practice guidelines published on myeloma in the 10 years preceding the search. And we compared our questions to the literature to see if they'd already been answered. And 7 of them were, but there was a gap in translation there where these questions had been answered by research, but the myeloma community didn't know about them. So we do hope to create some FAQs or educational sessions around this. And this left us with 59 questions that were within the scope of our project and were unanswered. But the steering group thought that might be a little too many for the busy clinicians and the people with myeloma who may have cognitive impairment. So we combined some of those questions and reduced that down to 45, which were included in the next phase of our project, which was another survey. So this we refer to as our interim prioritization survey, where we asked participants to select and rank their top 10 questions for the future of myeloma research from these 45 questions. Again, we had about 600 people, 650 participants from across the country who completed this survey. And we used the results of this survey, did some analysis and used those to narrow it down even further to 18 questions that we then discussed at a prioritization workshop. And this last phase of the project we did in April of 2021. We had to do it online, of course, because of COVID, but we had 23 participants, people with myeloma, caregivers, and healthcare providers who attended. And it was facilitated by 4 neutral advisors who used a mixture of plenary discussions in small groups to reach a consensus on the top 10 research priorities for myeloma. And here they are. I'm so pleased to be able to share these with you today. So starting at the ones of lesser importance, but still very important, and building our way to the most important. People want us to develop, or not me, they want researchers to develop treatments specifically for high risk or aggressive myeloma. They want better ways to treat refractory, relapsed, and drug-resistant myeloma, and ways to reduce or manage the short and long-term side effects of myeloma treatment. Continuing on along a similar vein, ways to reduce, cycle, or stop anti-myeloma medications that will reduce the side effects but still maintain control over their disease. Preventing or repairing the the bone deterioration that Dr. Reiman mentioned earlier without negative side effects or surgery. And then looking at other ways to personalize a patient's treatment and looking at the impact of what the personalized medicine has on treatment efficacy and disease outcomes. And then moving along, again, we want to see new treatment with improved outcomes and fewer side effects, ways to improve the diagnosis of myeloma, so perhaps less invasive, such as not having those bone marrow biopsies, as mentioned previously, looking at those novel immunotherapies, and then, of course, how can they cure the disease. And what was really interesting about this list to us as the researchers is that it was very heavily focused on the pharmacological treatments. In this type of patient-oriented research and based on previous priority setting partnership projects like this, they found it was very common to have discrepancies between the research that is conducted, which is usually pharmacological in nature, and the research needs of the community. So we thought we might see questions related to alternative treatments, mental health, and so on. And while those questions did appear earlier on in the process, when it came down to really prioritizing what the myeloma community thought was most important, it really came down to things related to treatments and improving treatment and quality of life through that. And we think the results speak to the importance of pharmacological treatments for patients' quality of life and the need to address concerns related to these treatments. And there is certainly research underway in this field, but we're hoping that the results of this project will help provide funders and researchers with specific areas of focus within the very broad domain of treatment-related research. So what do we do with these results? So first and foremost, we want to share these priorities with the research funders so they can fund research that is responsive to the needs of the community. And as Dr. Reiman mentioned, Myeloma Canada, who is a partner for this, has devoted 50% of the funds raised from their 2020 Myeloma March to funding priorities identified through this project. And they're looking at having that call for funding early in the new year. And we've also focused on sharing these priorities with the researchers directly through conference presentations and academic publications in leading journals. And we hope that this will spur systematic reviews and original research related to these topics. So in terms of next steps, we are working on a press release with Myeloma Canada and looking at sending that out to medical journals and other funders such as those related to this slides. And that's going to go out in early December. And we also want to share these results back to the myeloma community and to the general public to raise awareness around myeloma. And as previously mentioned, creating FAQs or educational sessions around these questions. And we hope that together, all these forms of knowledge translation will help to improve the lives of those who are affected by myeloma. And that is it. So those are funders of many of the projects that Dr. Reiman mentioned, as well as specifically the Myeloma Priority Setting Partnership.
Thank you, Sam. So I think that concludes our formal presentation.